some components that may dictate the appearance of inflammation, which plays such an important role not only in cardiovascular disease but also in cancer. So I'm very pleased that Dr. Virk will talk to us today about basic stuff that we all need that. Okay, so whenever he finishes, and we will be ready. And thank you for the great food that we.
No problem. Thank you.
To nourish our minds and our bodies.
Good afternoon, everyone. With the vascular surgery, the topic today is endovascular intervention. I'm going to talk about the basic techniques. We'll cover a few slides on the history, and then talk about some radiation, how to get less exposure to the radiation, then talk about some wires, catheters, balloons, and just basic stuff. Don't have any disclosures. So talking about the historical background, it started in 1927. Moniz at the University of Lisbon. He was the first one who did a cerebral angiogram, and that too using sodium iodide. That was followed up in 1929 as the first aortogram performed by Dr. Santos. In 1949, this was the first attempt on the percutaneous access. A blunt trocar was used. The access was obtained in the common carotid artery, and the thoracic aorta was accessed percutaneously. Following that, in 1953, Saldinger, and this was the first description of soft catheter rather than the metal trocar that was used. Johnson in 1949. This was to get the percutaneous access. So we started from 1927, we came to 1953. And following that, everyone knows Dr. Charles' daughter in 1964. He demonstrated the technique to cross the atherosclerotic lesion. He was the first one to describe the flow-directed balloon catheterization, the safety guide wire, and the J-tip guide wire. Then following that, Andreas Grunsick, he developed the technique of balloon angioplasty, and after that, Dr. Palmas came with the first balloon expandable stent that was used in 1985. This stent is still being used, and we use it most of the times for the type 1 endoleak, repairing the abdominal aortic aneurysm. We used it recently. It's the same way he had done it, so it's still being used. So once we decide we're going to intervene on a patient, a few things are very important. Obviously, pre-operatively, you have to make sure the patient is on some kind of antiplatelet. I usually prefer the patient to be on aspirin. If I'm doing a carotid, definitely Plavix for at least 5 days. I have canceled the procedure if the patient is not on Plavix for the carotid intervention. So talking about going forward, when we bring the patient to the vascular suite, we have to make sure they're good candidate for sedation, and we have to decide what kind of analgesia or anesthesia we're going to use. So the options with us is just do it under local anesthesia, use 1% lidocaine. You have to make sure you have good hemodynamic monitoring in the room, blood pressure, oxygenation. And then coming to sedation, usually use Versed and fentanyl. Here we have anesthesiologist available all the time, and most of the time the CRNAs are doing the cases. But in case you do not have the anesthesiologist personnel, you could do fentanyl and Versed. You have to make sure you have ACLS certification for that. The initial dose of fentanyl is 0.5 microgram per kg. Usually starts with 25 microgram, and for Versed is usually 1 milligram. So usually you give like a 51 or 25 one. Usually prefer general anesthesia for the complexity and the length of the procedure. Most of the peripheral interventions are done under local anesthesia and the monitored anesthesia care or light sedation. We use general anesthesia most of the times. Sometimes the patients, they do not lie still. It's very hard to get the imaging done. So at that time, the patient is a good general anesthetic candidate. We elect to put the patient to sleep. So coming to the fluoroscopic principles, the couple of things doing the DSA is the image acquisition. What does the DSA do is it removes the background structures with the computer-based subtraction, and this creates a very high fidelity image, and you can use very low amount of alternated contrast material with the DSA. And a little bit about the road mapping. This is the use of an image that is selected from the DSA. So you already done the DSA and it's overlaid on the monitor and during live fluoroscopy, and this limits the number of the angiographic runs, and this facilitates access during interventions. For example, if you're coming up and over the bifurcation, sometimes the wire keeps going into the internal iliac artery, and at that time you can do a DSA image and then do a road map and to see where the internal and external is, and you can guide your wire in the external iliac artery. So coming to the contrast injection techniques, usually the principle is the rate and the total volume, the contrast. The more the greater the size of the vessel, the more amount of contrast is used, and the amount of the rate increases. So the two types of catheters. The one is a flush catheter. Flush catheter, we'll go to those catheters in a little bit. These have holes for a little bit distance, and the end hole catheter is just one hole. So flush catheter, usually you can go, the pressure can be as high as 900 psi, and for an end hole catheter, it's like 300 to 500 psi. You have to always make sure whenever you're doing an aortogram, you put your flush catheter and you do the angiogram, but when you go sometimes up and over the bifurcation, if you're using an angle glide catheter, that's an end hole catheter, and you have to tell the tech, please decrease the pressure. There's a chance the vessel can rupture, can form like dissection as well. So looking at, so talking about the contrast, the rate and the volume. So usually in the aortic arch, so let's go from up to bottom. Aortic arch, usually it's by the injector. You inject contrast, and I usually use the same amount, 15 ml per second for total of 30 ml. And depending upon the patient's creatinine, you can use a half strength contrast, and you can dilute the contrast. So aortic arch is 15 for 30. Same way as abdominal aortogram, I usually use the 15 for 30, and aortic arch also flush catheter, abdominal aorta also flush. If you're doing a carotid or like subclavian, then it's an end hole catheter, and I usually hand inject. And for the cerebral angiogram, I use full strength contrast for better imaging quality. SMA, celiac, again, end hole catheter. The way small vessel, go for end hole catheter. Big vessel, aortic arch, abdominal aorta, use flush catheter. And then for agonal segment also, end hole catheter. And strategize to minimize the radiation exposure. So whenever we do procedure, we do procedure every day. So we have to make sure we are protected. And obviously the patients are protected too. You have to watch the fluoroscopy time also. So the modification to image acquisition technique is you minimize the angiographic runs, use DSA, and that can also minimize the contrast use. Always tell tech to decrease the frame rate and use the minimum fluoroscopy time. Use roadmap, use your reference imaging. If the patient already has a CTA, you don't have to do a aortogram on the patient. If the patient has a good CTA, you look at the images first, go to aortogram, you just go up and over the bifurcation if you're doing a peripheral intervention. And you increase the kilovolt and lower the milliampere settings to decrease the radiation exposure. And the other thing about minimizing the radiation exposure is how to decrease the scatter radiation. This is very important. Sometimes we like hook up the injector and tell the tech to start and do a runoff, and we just like stand there like in front of like II. So there's a lot of scatter radiation, so you have to be a certain distance away from it. You have to make sure you use leaded shields, your thyroid shield, move the table far from the radiation source and closer to the II. That's very important, closer to the II. Remove all metal objects to reduce scattering, use collimation to decrease the image size, use filters, and avoid routine magnification or extreme angulation because the scatter increases a lot with these things. So once you got the patient sedated or whatever anesthesia we're using, you already talked to the tech, what's your plan, how you're going to handle you already have your lead, your contrast, looking at the creatinine, whether you're going to use half strength or full strength. Then comes the patient is prepped on the table for you, and the most important thing is how we're going to do the access and where we're going to do the access. So most of the time I use ultrasound guided access. If I'm doing a peripheral intervention, mostly it's the retrograde femoral access, and most of the times the common femoral artery. Sometimes I do antegrade sticks also. The ultrasound guided arterial punction, usually you use 5 to 10 megahertz probe. It allows both the B mode as well as the color flow imaging. And the typical radiographic landmark for the common femoral artery is the middle third of the femoral head. So right there. So what I usually tell the residents is I usually put a hemostat on the femoral head and the middle third of the femoral head. So that gives me the indication where the common femoral artery, in case I'm not using any closure device, so we can hold pressure on the common femoral artery against the femoral head, as well as because the common femoral artery, if you puncture below on the profunda, there's always like a profunda vein that crosses, and this can cause like an AV fistula. If you puncture it higher, this can cause a retroperitoneal hematoma. So accessing the common femoral artery is very important. So hemostat on the femoral head, localized, and then I use the ultrasound as well. If the vessel is heavily calcified, sometimes I use the fluoroscopy guidance, and if it's not, usually use the ultrasound also. On the ultrasound, you can look at the common femoral vein, the common femoral artery, and then bring your ultrasound down, and then you can visualize the SFA and the profunda. And then you can do a longitudinal view also. And then here's your ultrasound probe. This is the inguinal ligament, usually from the anterior superior iliac spine to the pubic tubercle. That's your inguinal ligament. And you divide 1/3 of the distance. That's your common femoral artery. So once you visualize with the ultrasound, you come at 30-45 degree angle with your needle. I usually use a micropuncture needle to get the access under ultrasound guidance. And you have to be very careful. So if the needle is very close by here, then sometimes it's very acute angle. It's difficult to pass the wires and the sheath. So you have to make sure you're a little bit away from it. And sometimes I've seen that the problem is you have the ultrasound here, you're getting the needle, and you're not able to see the needle tip. And the needle tip is past your beam, past your probe. So you have to make sure that it transects easily. So it's easy to see the needle tip when it's very close to the ultrasound probe, but the angle is not right to get your wires and sheets in. So you have to be very careful when you do that. So this is demonstrating the same concept I just talked. If it's very close to the ultrasound probe, most of the time it's easy for you to see the needle tip, but you can lose the needle tip as well. But the angle will, like putting the wires and sheets, is sometimes difficult. So you start a little bit behind to get the access. So now you've got the access, then comes the guide wire selection. So I usually start with the micropuncture needle. Micropuncture kit has a 018 wire, short wire. You put the micropuncture needle in, 018 wire, take out your micropuncture needle, and then you put it's a 4 French small micropuncture sheet. Once the sheath is in, you remove your dilator, and then you put the wire in. Usually I use a 035 angle glide wire, depending upon, and if I think there is going to be some dissection, because the glide wire can dissect the artery, and that in those cases I sometimes use a Benson wire. It's like more floppy and less chances of causing a dissection. So this is these are like in inches, 014 inch wire, 035 inch wire, and 018 wire. The bigger the wire, so usually for subclavian SFA intervention, you use 035. Whenever you get a retrograde common femoral artery access, after you put your micropuncture sheath in, you put a 035 angle glide wire. And whenever you want to do the intervention in the carotid, vertebrals, or infrapopliteal, that's a 014 wire. 018 can be used in the SFA or infrapopliteal, and depending upon the quality of the wire and what kind of lesion it is, sometimes you have to use like a weighted wire. It's a more grams like in front of the wire. So these are there are several brands of wires available. So these are a few 035 inch wire which we usually use for the bigger vessels, common femoral, aorta, arch. So these are all manufactured. Cordis, Terumo. I've talked about Benson wires from Boston Scientific. This is the initial access wire, working wire. So you see there are a lot of wires, but you have to make sure you use few of the wires to get comfortable with, and then make one of your wire as like your working, it's like your favorite wire which you can use it easily. But get accustomed to like several wires, get the feel of those wires, and once you are head in your training, you can come to like down to 1 or 2 wires. So talking about, this is a straight glide 035 wire. This is the angle glide 035 wire, and this is a J tip on the wire. Nowadays they have J tip angle glide wires also. So talking about the catheters, we talked about the flush catheters and end hole catheters. Flush hole catheters have multiple holes, and these are mostly used for abdominal aortogram or arch angiogram. And the varieties are omni-flush and a pigtail catheter or a straight flush catheter. And then you have several types like Compi, Cobra 2, depending upon which vessel. For renal vessels, a headhunter, sometimes you can use in the carotid or side winder, or Simmons 1, Simmons 2 for like a bovine arch if you want to do a carotid intervention. Omni-flush catheter can be used to go up and over the bifurcation also. So if you want to do first do abdominal aortogram and use same omni-flush catheter to go up and over the catheter, or up and over the bifurcation of the aorta. And most of the times, a lot of people use a rim catheter to go up and over the bifurcation of the aorta. So this is the technique that's demonstrating going up and over the bifurcation. So you have this is source catheter, and then you have the 035 wire. Then you pull back your wire in the catheter, and this forms the catheter, and then you sit it over the bifurcation, and then you advance the wire. In omni-flush catheter, or we use here is a contra catheter. I usually do the abdominal aortogram, and then I bring the wire back into the catheter, and then I slowly make sure the tip of the catheter is facing anteriorly, because if it's not anteriorly, then it's most of the times it's going to go into the like lumbars or like renal arteries. So you have to make sure you pull it anteriorly and then face it the contra side, whichever side you want to select, and then pass the wire. Once you get your wire passed into the external iliac artery, then you slowly advance the catheter over it. Sometimes it's very difficult to go one up over the bifurcation, then you use a rim catheter. Sometimes you have to use a stiff wire depending upon. And one of the time I had to come from the other side, snare the wire, and put a bigger sheet, use 014 wire for the support, and 2 wires to get up and over the bifurcation. So a little bit of about crossing a stenosis. So whenever you're advancing the wire, you have to be very careful, even if it's a stenosis, like how the wire is going to behave. So tactile is very important, and looking up the image is very important, because the subtle deflection of the guide wire and the tip, it's very like how it looks. If it's like having more bends, then most likely you're in like a subintimal plane. And sometimes you have to allow it to make a short loop at the leading end of the guide wire, and this can facilitate the passage. And you put your support catheter on the top of it, and you can advance and cross it. So this is the image that's demonstrating. So this is like a SFA stenosis. So wire, you form a loop. It's like a loop technique, and you have your support catheter on the top, and you slowly advance the wire and the support catheter, and then you get into the and then you cross the stenosis, and then you can balloon. But you have, after you cross the stenosis or the occlusion, I usually advance my catheter, and few things I do to make sure I'm intraluminal. The first thing I do is I draw back, and you have good blood return in your catheter. That means you are intraluminal. And then I inject a little bit of contrast to make sure you are definitely intraluminal. Because even if you're doing a subintimal angioplasty, you have to make sure you're in the distal part, you are in the intraluminal. Otherwise, it's not going to work. You're going to cause a bigger dissection rather than doing like a ballooning the stenosis. So this is one of the subintimal angioplasty, ostial SFA occlusion into the subintimal plane, but made sure we were intraluminal distally, and then balloon stented SFA angioplasty. So pitfalls and danger points whenever for the peripheral intervention, I usually discuss with the residents is there's a possibility of embolization, there's a possibility of dissection, there's a possibility of rupture. So you have to explain everything to the patient also before you start the procedure. So coming to the angioplasty, so you got the access wire, cross the lesion with your wires, support catheters. Before any angioplasty, you have to make sure the patient is fully anticoagulated. I usually use 100 units per kilogram of heparin. If I suspect this is going to be a long case, I usually have an ACT machine available. I usually check my ACTs also. For example, if I'm doing a left leg intervention and I have access in the right common femoral artery, I give heparin once I put an up and over sheet, a destination sheet or a long sheet. If I'm just doing a diagnostic angiogram, I usually use a 4 French sheet, and I usually do not give heparin for a diagnostic angiogram. But for any intervention, once I put the sheet in, you have to give the heparin and then put the sheet. Wait for 3 minutes and then put the sheet. And depending upon how long is the procedure, you have to check the ACTs frequently if you're spending too much time. And so therapeutic dose, we talked about 50 to 100 units. Most of the people do 80. I usually tend up doing 100 units per kilogram. So in the angioplasty is you exert more radial force. There is plaque rupture, intimal injury, but this causes a larger flow channel. That's the purpose of angioplasty. And most of the time, the SFA, when you intervene, you come across dissection, and then you have a big question: oh, shall I stent this or shall I not? So depending upon how the flow is through your post angioplasty, if it's non-flow limiting, very focal dissection, I usually leave it alone. Or if it's a flow limiting dissection or it looks like very ready SFA, then I'll probably put a self-expanding stent in it. So talking about over the wire and the monorail rapid exchange system balloons. So this is a balloon that goes over the wire, and this is for rapid exchange, for example, for the carotid intervention stuff. Use over monorail system and for below the knee also. So this is angioplasty that demonstrating. So you cross the stenosis. So this is your balloon. You position it to straddle the stenosis. Then the balloon is inflated, and then you watch it on the angiographic image, the waist of the balloon. That's called the waist, like how big was the waist, and you watch it. And then the waist is visualized, and then you balloon, then it disrupts the intima, and then you take a post-angioplasty picture, make sure there's no flow limiting dissection, which you have to stent it. A little bit about semi-compliant and a non-compliant balloon. Semi-compliant balloon growth is more significant as the pressure increases. There's more growth. Grows in areas of very least resistant. And so what compliance is? Compliance is the ability of a balloon to grow with the pressure. So semi-compliant, it grows more with pressure. Non-compliant usually does not grow as much as a semi-compliant balloon. More used for calcified, very resistant vessels. So this is so we have regular balloon angioplasties, and then this is a cutting balloon which has razors on the end, and it cuts the intima. Most of the time it's like a controlled dissection, and then you can do, after this you can do a drug coated balloon. Drug coated balloon, most of the time they have paclitaxel drug, decreases the proliferation, and so cutting balloon and DCBs then. Now talking about the stents, two main type of stents. So we have a balloon expandable stent and a self-expandable stent, and the third variety is a stent graft. So the difference between these three is, for a balloon expandable stent, I use it whenever it's an osteal lesion. For example, it's a common iliac lesion, use a balloon expandable. Renal, SMA, balloon expandable, and in which you want to have more precision, you use a balloon expandable stent. It requires positive pressure for expansion. It's very rigid with a high radial force. Whatever the vessel size is, go with the same size stent. You can overinflate it. And this is for mostly for the immobile part of the body, like subclavian, renal, mesenteric, iliac, and at the osteal location, and where you have to have precision, you use balloon expandable stent. Coming to the self-expandable stent, usually in the SFAs, where it's very flexible, twist during the movement, like neck, carotid, axillary, SFA, or popliteal artery. They're 9 tall. They have good flexibility and very good memory. And this self-expanding stent, that is compressed over a delivery catheter, and it's covered with a sheath, and you usually unsheath the self-expanding stent. And the important thing is the stent diameter should be 1 to 2 millimeter greater than the reference vessel. For example, it's 4 millimeter vessels usually use a 5 to 6 millimeter self-expanding stent, and this gives you the adequate stent apposition. And in balloon expandable stent, you use the same diameter vessel, same size stent. For example, it's 5 millimeter, use 5 millimeter. And self-expanding stent always go up 1 to 2 millimeters. So we talked about the balloon expandable stents. This is the mechanism. It's mounted on a balloon, and once you get to the lesion, you inflate it to the nominal pressure, and this is how it looks like when it's expanded. And this is a self-expanding stent. It's placed on a sheath, you unsheath it, and this is a self-expanding stent. So the third thing, so we talked about balloon expandable stent, we talked about self-expandable stent, and the third thing is stent grafts. Stent grafts are basically covered stents. The use is to exclude an aneurysm or to treat perforations. So you have to be very familiar to these stent grafts. For example, if you get into a rupture or a perforation, if you're doing a dialysis access, sometimes you rupture the vein or rupture the dialysis access, you can bail out with putting a Y-bond. It's a covered stent graft. So wall graft and Y-bond are the two stent grafts that I used. And recently, the company Gore has come up with a balloon expandable Y-bond kind of VBX also. And we used, Dr. Rao used it today and in the left common iliac. So after all these interventions, so the important thing is how we're going to manage the post-op care of this patient. Usually once the procedure is done, it's not like it's your patient, you have to follow up the patient also, and you have, as I said earlier, before we started the procedure, we have to make sure the patient is on some kind of antiplatelet therapy, especially for carotid, aspirin, Plavix for 5 days. And definitely for peripheral intervention, I'd like most of the patient to be on aspirin at least. And I prefer Plavix post-op. There is no level 1 evidence for how long the Plavix has to be continued. For the carotids, I just keep them on Plavix forever or until they have any issues. For the peripheral intervention, at least 3 to 6 months, depending upon the patient's tolerability. And I usually see them in the clinic. You get a non-invasive vascular studies, duplex, ABIs, and then I compare it with the preoperative non-vascular studies and see how the intervention has helped the patient, and talk to the patient about the symptoms as well. So this was from pre-op, getting the patient to the operating table, analgesia, balloons, catheters, very basic stuff. I think so we use it every day. Any questions?
Before before you do the procedure, you always place your patient on Plavix.
For the
You place
carotid,
Pre-
carotid, yes.
just carotid.
Carotid, yes.
Because I was going to ask, what is the risk of bleeding or what?
It's very minimal, very minimal. So the Plavix usually, it's aspirin is antiplatelet agent. Plavix is more potent antiplatelet agent, and it has shown to decreases platelet aggregation in the stent, decreases distal embolization. So it's very important to have Plavix on board for the carotid intervention. I usually tend to have only aspirin for peripheral interventions, just for more like plaque stability, decrease platelet aggregation whenever you do the procedure. Because you're causing like an intimal disruption or damage, and the platelet's going to come and adhere to that. So if you have antiplatelet agent on board before, so there's less chances of getting that.
It's not the normal dose of Plavix, it's a loading dose of Plavix.
Yeah.
It's not the normal dose that you get, you actually give them a loading dose of Plavix before the procedure all the time, because when doing carotid stenting, you're very worried not only for plaque rupture, you're very worried about sending emboli out.
Distal emboli.
So you always go to the Plavix, you tend to use the distal stenting device also to protect yourself. And again, as Dr. was telling you, wherever you do any lesion, any stenosis, anywhere in the body, renal, SMA, the guidelines are that before you actually pass a wire through the stenosis, you should have heparin on board.
That is different from the, another dose different from the heparinized saline that we use.
No, yeah, it's different. It's like approximately 5,000. So the moment you actually put your sheet and everything ready, and before you actually cross the stenosis, patient should be at least about 5,000 is different. So 5,000, 80 kilogram patient will come to a dose of about 80 to 100.
Yeah, we talked about that. Anticoagulation. Most of the people use 80. I usually tend to do a higher on heparin, 100 units per kilogram.
This is different from.
Yeah, this is different from this. That was
Interventional radiology does.
right.
They don't. The guidelines don't want Plavix days
So,
before.
you're talking about
It depends. We don't do too many vascular procedures ourselves down here. But the problem is when you have a thrombus, that is a problem.
Yeah.
Bleeding you can always somewhat control. But
All the
thrombus
bleeding
is
stops some point.
you know,
Thrombus
and
is difficult to deal
much
with.
vascular here. You know, then I want to congratulate you for the topic. That's a topic that I'm sure is very useful for the residents, especially the residents that are going to take the board exams. You know, you have an idea of different PSIs and everything. We do very little of that in interventional radiology now. And we very seldom talk about PSI, about volumes and everything. And also through the catheters. I appreciate very much, you know, and I would want and I wish that you can send us a template that when we dictate our vascular procedures are meaningful to you. Because sometimes we do the best we can, but it doesn't mean that it's going to be what you